As always, the Middle East Institute likes to draw attention to those urgent but neglected humanitarian issues that don't get enough attention but need more attention. We want to improve understanding, that's our mission, but more importantly, we want to galvanize action, and we certainly want to galvanize action in the issue of healthcare in the crisis zones in the Middle East. As my friend Dr. Alawan from WHO says, this is the important role of health diplomacy. So we are joining IMC in sponsoring this conference today to focus attention on the medical needs, the emergency medical needs, the surgery needs, the physical therapy needs, but don't forget the psychosocial dimension of it, which is extremely important, and we'll have much more to say about that throughout the day. Our speakers today are truly experts, not only from Washington, D.C., but broader scope, the United States, and from the region. We've brought several people in from the region. They're a little bleary-eyed, perhaps, a little jet-lagged, but they're here to share their views, their observations, their knowledge on what is happening right now in the field. One of our speakers, the Minister of Health from Libya, had a visa snafu at the very last minute. He'll be joining us by Skype, but he will be here intellectually anyway. At lunch, you'll hear the insights from the former and the most recent and last U.S. ambassador to Syria, who is now a senior scholar at the Middle East Institute, Ambassador Robert Ford. And we look forward to hearing what he has to say at lunch. But to begin with, to set the context, the political context for this conference, we have a very special speaker. I'm extremely pleased to be able to welcome and introduce to you Assistant Secretary for the Near Eastern Bureau at the Department of State, Ambassador Ann Patterson. This is the most senior U.S. government State Department official who deals every day, 24/7, on the issues of stability in the Middle East. And she's taken time out to join us, and I'm very grateful for that. Ambassador Patterson is one of our nation's most masterful diplomats. She is a career ambassador. That's as high as you can go in the American Foreign Service. She's been serving as Assistant Secretary, as I've said, in the NEA Bureau for the last couple of years. Ann holds, has been one of those ambassadors who's multiple ambassadors, but the department in its wisdom has only sent her to the most challenging posts. She's been ambassador to Egypt, Pakistan, Colombia, and El Salvador. In Washington, stateside, she's also had very difficult and challenging positions as Assistant Secretary of State for International Narcotics and Law Enforcement, as Deputy Permanent Representative at our UN mission, as Deputy Inspector General. She's been awarded almost every award you can think of. She's received the Secretary of State's Distinguished Service Award twice. She's the recipient of the Ryan Crocker Award for Expeditionary Diplomacy. And in 2011, she was named as one of Foreign Policy Magazine's top 100 global thinkers. Well, she's going to spend some time with us this morning thinking, and I'd like to welcome her to the stage. Immediately following her presentation, we'll go right into the first panel. So, Ann, thank you so much for coming.
Thank you very much, Wendy, for inviting me to speak to this distinguished audience this morning. This is an extraordinarily important issue, and over the years I've become to realize how important it is in the various countries in which I have served. You're gathered today to discuss a very important issue and one that will have significant impact on the development of the Middle East. Healthcare delivery systems across the region are facing acute crises, putting many millions of people across the region at risk. But as you know, healthcare is only one important part of a country's social fabric and economy. The profound instability and violence gripping some countries in the region over the past several years has done enormous damage to infrastructure and basic services that will take years to repair. Other countries are facing difficult choices and need new technologies and business process reforms to contain costs. We all know how difficult the debate over healthcare reform has been in the United States. In Syria, Libya, Yemen, and Iraq, violence and displacement are preventing millions of people from receiving care for their emergency and chronic health care needs. For Syrians, the situation has been most dire. The Assad regime's attacks on its people and the resultant growth of violent extremist groups have led to direct assaults against health facilities and healthcare workers. Polio, which essentially had been eradicated in Syria before the conflict, has resurfaced. Half of the country's pre-war population of 22 million people is either internally displaced or living as refugees in neighboring countries, severely straining social services in Turkey, Lebanon, and Jordan. The situation is also desperate in Iraq. In an astonishing attempt at propaganda, ISIL released photos of health clinics it claimed were operating in Mosul as part of its narrative of providing services to the Iraqi people. In fact, they turned out to be real British National Health Service clinics photoshopped with the ISIL flag. In Libya, the civil conflict has hobbled the delivery of health services across the country. Practically all the community clinics have closed. Major hospitals have been forced to take on the burden of routine healthcare services. The main trauma hospitals in Benghazi, Tripoli, and Misrata are overwhelmed trying to treat casualties that arrive at their doors on a daily basis. In Yemen, which was the Arab world's poorest country even before the outbreak of civil conflict, thousands of cases of dengue fever and other serious communicable diseases have been reported across the country. 15 million people are in need of basic health care, according to the WHO, and the health sector is on the verge of collapse. In a strange counterpoint to the health challenges due to war and instability, the wealthier parts of the region have been experiencing problems of a different kind, an explosion of the so-called diseases of the wealthy, such as strokes, cancer, and diabetes. Saudi Arabia, Kuwait, and Qatar have all been forced to make major investments in modern healthcare facilities and pharmaceuticals to address the changing healthcare needs of their citizens. The Gulf countries have been able to make major investments to pay for needed care, although with the price of oil currently half of what it was a year ago, the cost associated with these diseases will become unsustainable unless the current healthcare delivery systems evolve. This will require adoption of some of the efficiencies and cost containment strategies we have been struggling with in the United States. Looking at the situation in the region candidly, we see a healthcare delivery system that is no longer able to provide the services most people in the Arab world need or can afford. Many of the problems plaguing the industry form part of a larger systemic collapse that has contributed to the tremendous unrest we currently see around the region. These include unresponsive government services, rapid population growth that has overwhelmed the existing system, and an anemic private sector, slowed by inefficiency and government regulation, which is unable to deliver affordable health care. What's dispiriting is that not too long ago, healthcare was something of a regional success story. From 1970 to 2010, the Middle East and North Africa region registered the fastest decline in infant mortality rates in the world and communicable diseases stopped being the major cause of death. The so-called diseases of wealthy nations became the leading cause of death in the Arab world too. Egypt, where I was an ambassador several years ago, is illustrative of this trend. Over the past 15 years, Egypt pursued a largely successful effort to bring down the rate of infant mortality, which decreased by a third from 33 deaths per 1,000 births to 22 deaths per 1,000 births. Today, 90% of newborns are vaccinated, and prenatal and postnatal care for mothers has improved significantly. In Tunisia, infant mortality rates have dropped by 35%, and maternal mortality rates dropped by nearly 20% over the past 8 years. In Saudi Arabia, over the 2 decades between 1990 and 2010, infant mortality declined by 50%, and maternal mortality declined by 70%. In other words, in less than a single generation, there were massive improvements in healthcare, health education, and sanitation. However, we are now seeing serious structural deficiencies across the board, and this speaks to a larger breakdown in the Arab world. The social contract between Arab governments and their people was that the government would provide education and social services in return for support. But as costs have risen in the context of slow economic growth, governments have been increasingly unable to deliver on their part of the bargain. Access to health care has become inconsistent at best. As a result, popular discontent with governments has grown, and it remains high. In the case of Egypt, for instance, we have seen that doctors, particularly those practicing in rural areas, are very poorly paid and face few repercussions for providing bad service. And because most Egyptians cannot afford private health insurance, it can be catastrophic for families if someone becomes seriously ill. The average per capita cost of health care in the region in 2003 was $115. By 2013, it was $315 per person, a nearly 10% year-to-year growth rate. But the governments of the region have made commitments to their citizens. In Saudi Arabia and the UAE, and probably most of the Gulf, the government pays for about 70% of the country's healthcare costs. Lebanon pays for 50% of all healthcare costs. Egypt and Morocco cover between 35 and 40% of the nation's healthcare costs. These outlays are unsustainable over the long term. They are stretching and putting pressure on government budgets, which also are subsidizing the cost of energy and water and growing outlays for military expenditures. In the coming years, these systems will be further stressed by demographic change. Half of the region's population is under 25 years old. As this generation matures, starts families, and particularly ages, they will place an even greater burden on the healthcare system. Well, what can be done about this problem? Going forward, the region will have to continue to change how acute and long-term health care is delivered. This is a process the United States understands very well from our own experience and struggles with this issue, and we have actively engaged in trying to help our friends in the region. First and most critically, we are working to save lives and support refugees in countries where there are ongoing wars. Working with our multilateral partners, the United States is the largest contributor to these crises, providing health services where possible through the World Health Organization, the International Committee of the Red Cross, and many international NGOs. These organizations are operational on the ground and are frequently best positioned to provide emergency and heroic assistance to the people who need it most. In Iraq, over the past 2 years, the U.S. will have spent $17 million on healthcare programs benefiting internally displaced people who have fled ISIL and other violence. These funds complement the $200 million in humanitarian assistance we are providing to Iraq. We have seen that these conflicts are not self-contained, but rather bleed across borders and seriously strain neighboring countries' social services. That's why we've also provided more than $1.6 billion to Jordan, Lebanon, and Turkey to mitigate the multiple stresses, including health care, that hosting people fleeing these conflicts have placed on regional partners. Second, in countries where healthcare delivery systems are not overwhelmed by conflict, we are urging greater transparency and modernization of the healthcare sector. Governments will need to address and develop safe and responsive healthcare capacity. Given budgetary constraints, this will largely have to be done through private investors and service providers. In addition to investment in infrastructure and new technology, there is tremendous demand for doctors, technicians, pharmacists, general practitioners, and a host of other healthcare professionals. This is, generally speaking, an underdeveloped industry. It could offer a wealth of potential jobs in a region that faces employment shortfalls. In the interim, the U.S. is also providing direct aid to some countries in the region so important healthcare goals can be met, including efforts to cut back on the corruption and inefficiencies which also plague this sector. Last year, the U.S. provided more than $160 million in healthcare assistance to countries and institutions in the region. And for instance, to take one example, we are working with the Palestinian Ministry of Health, among others, to develop new guidelines in electronic records to cut unneeded and costly referrals. Last year, this system helped reduce the number of referrals to Israeli hospitals by around 50%, saving the Palestinians nearly $5 million a month. And we have invested in hospitals for many years, and I think many of us who have seen USAID's activities in the field and healthcare are very proud of this. In Jordan, for instance, 70% of all births are now delivered in public hospitals that were renovated with funds provided by the United States. But the magnitude of the investments required in the region are so great that bilateral assistance and emergency programs cannot do much more than plug obvious holes in the system and address the most urgent and critical humanitarian requirements. What's needed is economic growth and investment, and for that to happen, regional governments need to provide political and economic stability, something in obviously short supply. I'm looking forward to hearing about the programs you're working on and solutions you think ought to be pursued to address the myriad crises in healthcare affecting this region. Providing and improving healthcare will be a long-term effort that will require governments, healthcare professionals, and industry all working together. So I thank you very much for your attention this morning. Thank you.